Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about patient dependency, especially in regards to manual therapy and does it cause it? There's a lot of debate about that and whether it causes people to have to rely on physical therapy or manual therapy. So we're going to put our 2 cents in, but before we get into it, Brandon, how's it going?
Oh, well, Jer, looking forward to this topic. I mean, this I think can have or does have a lot of tentacles and legs on it, and we'll see how many of them we can touch upon and cover. I don't think there's a right and wrong answer. Really, a lot of different viewpoints here. So I'll try and do my best playing some devil's advocate along the way.
That's good. Yeah, I think it should be fun and yeah, hopefully we'll probably ruffle some feathers as it is. Hopefully we don't get any bad reviews or anything like that.
I was gonna say ruffling feathers. We're gonna drink on the show and we're gonna curse on the show, and that'll be that. So
There is a explicit warning on this, as there always has been, but I'll try and be better and hold the tongue here and there. But anyhow, before we get into
I won't.
Hey, well, there we go. Go all out, baby. Brandon, what are you drinking today?
So I got my big bottle of Don Q Anejo XO. It's a Puerto Rican rum. Delayed shout out here from one of our stellar interns, John V from NYU. John, haven't forgotten about you. Haven't forgotten about this bottle. Just been busy with a lot of stuff, and I had a lot of other bottles I had to kind of get through here. But John was a great intern. We had him. He reminds me. I was telling you. He reminds me of our friend Kyle Feldman. He's been on the show, and Kyle, I always look up to him in terms of his ability as a clinician, as a person. He is, the I don't know, patience for days, which I don't. His ability to display empathy and communicate and show compassion is really something I look to, and I often find myself, when I'm frustrated or maybe stuck, like I'm like, what would Kyle do? And I see a lot of that aspect that Kyle has in John as well. So some pretty big shoes there, John. But good job, congratulations. Actually, we had a recent post about him on our Instagram, and the love for him and support for him was overwhelming. So kudos to you. We wish you luck on the rest of your PT schooling. I know you got about a year and a half left there. Actually, probably less than that because we had him last summer. Probably a year.
Oh, all right.
But anyway, smells delicious. This is apparently he went straight to the motherland for this one right here. So
yeah,
good stuff.
That's awesome. So he brought it back from Puerto Rico.
Yeah. So this is my first time having it. I'm gonna have it on the rocks. I don't want to miss any of the flavors here. This bottle's legit too, man.
I know. I even know Anejo like of a rum exists. I thought Anejo was a tequila thing.
Yeah, I know. Me too. So I was pretty shocked when
Smell test, a swirl test.
Oh, dude, that's smooth, man. Not even. I mean, you guys didn't even see a flinch or anything. That's beautiful. That's really good. All right, John. Thank you very much. Cheers, brother. Excellent. Hopefully, we'll touch base soon.
All right,
Jeremy, what you got?
That's John, I probably not as nearly as interesting or probably as special as yours there, Brandon, but I got a Stone Vengeful Spirit IPA. So hopefully some vengeful spirits come out of us during this episode. IPA is the last of the pack, so I figured finish it off with pineapple, mandarin orange. So it's got some flavors in there. And I'm excited to have it. Drinking out my local bone saw glass. Oh yeah, my pouring skills have improved.
Oh, look at that! Look at that! I got the little twist at the end there.
Screw this! I'm gonna become a bartender, but just pour beer.
Yeah.
I can definitely smell I believe the mandarin on this. It's good. Definitely get some fruit. If I go for an IPA, it's usually some with a fruit. I'm not just your standard IPA kind of guy. So that's pretty good. I'll give it a 7.5. That's the first thing that comes off the top of the head.
Oh, 7.5. I thought you were going to loosen up on the grading here.
Yeah, I know. I'm waiting for it. I'm waiting for that one that just blows my T's into outer space. And but yeah, that's probably gonna have to be, what we had at the brewery after the course. Those are probably some higher ranking ones. So I'll have to bring them on.
Which one did you have?
I had the Ooh La La, like you did.
I like
had
that.
I guess black IPA that had that.
Okay, you had the same ones then. Okay.
Yeah, so those were pretty awesome.
I like those. The Ooh La La kind of tasted like a cream soda esque.
Mm-hmm.
So I'm all about that.
Which was cool. Yeah. I haven't had a bad white stout yet. Just they're hard to come by. So Anejo, our local brewery, has one.
They kill it, man. They're crushing the game.
Doing awesome. I had another one, the pumpkin chino that Marta had from Neck of the Woods. And I had it during a business meeting, executive meeting amongst my team yesterday. So I was supposed to save it for the show, but it was looking so good. So I had it again. That would have been one that was probably at least in the 8s, maybe a low 9. But if I get it again, I'll have to hit Neck of the Woods Brewing and get that. I'm lighting up a little bit on my rankings. I mean, I'm becoming a bit of a beer snob with these rankings, so I'll have to loosen up. But cheers.
Cheers. Executive meeting sounding big time, bro. Sounds like
trying to get to that big time.
The IPO and everything going.
Yeah, right. We're going public next week. Everyone buy their stocks of Try.
Hopefully they're doing it. Hopefully your IPO would do better than ATI's.
Oof. Well, they dropped like I forget how many percentage over there. It's like 30-40% or something recently.
So
yeah,
I don't know too much about it. I think there's like some lawsuit going on.
They got a lot of issues going on. Terrible. Apparently, not the greatest retention and that sort of stuff. Not to talk bad on them, but they have to air their dirty laundry out now that they're public. So, it's been interesting to follow them and see if their stock rebounds. But yeah, I think it's dropped a bit. But
yeah, I think they said the biggest cost of running a business is employee turnover. The amount it takes, the physical amount, and then when you compound that by the time it takes to train people,
especially if they're
constantly training, is your biggest I can't even talk. Biggest expense. There we go.
Yeah.
Jeez, what's in this? What's in this? I can't even talk.
Well, 100 proof.
I don't know, man. Might be up there with the 151. No, it's not 100, it's 80.
All right, solid, steady.
So, all right. So, what we got here, man? We start us off with a couple questions, and I'll run my flapper.
Yeah. I guess the big thing I've seen it here and there on social media. We've had a couple conversations about manual therapy, whether it should be implemented or not. But one of I guess the main things of the individuals that suggest we shouldn't do it or it's not necessary is that it leads to patient dependency. If we perform manual therapy, it kind of puts the idea that patients need us to fix them and will continue to come back every little ache or pain or injury, or they will only be fixed as long as we do some hands-on techniques. I guess straight off the bat, Brandon, your experience, I know we're obviously biased. Obviously, if you haven't picked up from even the show title, Nips, not man nips. All right, I want to hear this from a couple people. Why is the show called Man Nips? All right, that's two separate words. This is Nips. But obviously, we're biased. We've played around with a lot of things in our careers, and manual therapy is kind of stayed true for us. But Brennan, in your experience, do you feel like manual therapy can cause dependency?
Yeah, I'm going to sidestep this first question right off the bat here. I'll come back to it. I'm just sidestepping right now, a little juke. I'm going to
Shake and
broaden
bake
it
me.
away from manual therapy manips and talk about the profession as a whole. You know, we're like the only profession that like shoos patients away.
Mm.
Like the need for like fewer discharges or not fewer discharges, fewer sessions. I get it. We need to have value. Obviously, we've done residencies and fellowships. We've gone through the outcome forums. We've gone through the training to get our numbers where they need to be. Like, if you guys don't know our background, that is it. We totally get it.
Mm-hmm.
But in terms of the profession, like we're trying to grow that piece of the pie that we see. I mean, and even expand into maybe the ER realm, right? We have doctorate behind our name, which a lot of PTs still don't even know what that freaking means. You know, we talk about being able to rule out red flags and things like that. Well, then why aren't we becoming the number one? And which this is APTA's vision of 2020, which we're in 2021 now, almost 2022. And I think at the latter half of the 2010s, they I guess lowered their expectations, APTA, of the becoming the number one provider for musculoskeletal pain. Well, if we're going to be that number one provider, we need to actually see more people. We need to have people depend on us. We need to have people want to come back to us every time something is wrong with them, so we can tell them, hey, you just need X, Y, or Z, and we're steering them away from low valued care, such as massage, such as injections, such as surgery when not needed, which, let's be real, most of the time we probably don't need it. All right. So if we can save somebody that time and risk and money of other methods, opioid epidemic that's going on, and see them, even if it's for a handful of sessions for manual therapy or some other form of physical therapy, why is that not okay? Why? In a way, I want my patients to be dependent on me. I want them to come back to me. I want to be the gatekeeper. All right. You know, egos aside, I want them to trust me so much that they'll value my opinion over a surgeon. I have a guy right now came in. He's been dealing with knee pain for 2 months, maybe 3. He slipped on his desk, tweaked his knee. You know, we're going through all the tests, you know, ruled the ACL, probably has a meniscal tear, or at least his meniscus is pissed off. Let's put it that way, right? Maybe it's a little irritated. Valgus stress test showed positive, but I think that's just more from the swelling and irritation and sensitization that's occurred over the past 2 months. Hey, I think you're having this. I think we could definitely help you with physical therapy. We just got to get that swelling out of there, get you walking right again because you had a patagic gait, obviously, and you'll be fine. In the meantime, yeah, go check out so-and-so. Let's see what he says. You know, we referred him to a doc. He wanted to see a doc. Cool. But he went to see the doc. Doc was like, yes, it looks like a meniscal tear. Let's get you an MRI, and we're probably going to do surgery right off the bat. Boom. Not, hey, let's finish therapy and see how that goes. My patient calls me back up. Hey, I'm going to get the MRI, but I'd rather, try PT. It's already feeling better after 1 session. So if I can avoid surgery again and we do this for 4 or 6 weeks, great. Like that's great. I want him to be dependent on me and not that quick fix, because a lot of surgeons, at least up here, meniscal tear, let's do surgery. You don't need PT. You'll be fine. And you'll be walking out. You'll be fine in a couple of days, which is almost never the truth, especially for, guys or manual laborers, construction workers, things like that. They're on their feet constantly. They're not going to be better in a month. So that's my sidestep on the manual therapy topic, and more so into physical therapy as a profession and where we need to, grow a sack and be better advocates for ourselves and for our profession. And I really think that comes to us knowing prognoses, knowing diagnoses, knowing differential diagnoses, not treating on pathoanatomical diagnosis anymore and treating more on impairments. I'll keep going, but I'll let you talk.
Yeah. I mean, do you think right now as a profession as a whole, that we should be that? I think recently even AOMP said something about, us becoming the primary practitioners of neuromusculoskeletal. I think it's NMS, I guess. of conditions and that sort of stuff. And like looking back at, obviously I full wholeheartedly agree. I treat primarily direct access, or now it's getting a little bit more balanced, but I did that so we can avoid situations such as the one that your client was in, that we do become that first option. And we can avoid the things if we're looking at things of like, all right, low value, high value, whatever the hell you care, more risk to reward ratio of things. It's all right, what are the options for said meniscus tear? Okay, we can do injections, which cortisone, and then there's still individuals out there that'll do multiple cortisone injections, and then you're just screwing the person down the long road. If they get onto the opioid train, which I haven't seen as much, but that's addiction. And then we have surgery, and we always kind of think of surgery as this, people still think that it's like, oh, I get surgery, I will be fixed. And a lot of times it's, if we're looking at the whole person and we're looking at the every part biopsycho and social components, a lot of times surgery doesn't fix the psychosocial components that an individual is going through, and then the risks associated with it. Talking with Chris Carroll, who's did the PT Reframed with us, he gets people all the time going for standard orthopedic procedures. And if you don't know Chris Carroll, didn't listen to his episode, he works at McGee for in their neuro intensive unit, and he gets people who were there for an orthopedic procedure and end up in his hands because something bad happened, stroke, blood clots, whatever it may be, heart attacks. So yeah, I mean, I think obviously we're the safest option, but going back to things, do you think should we be universally accepted? We should get a public service announcement that announces, listen, everybody, that you have a neuromusculoskeletal issue. If I guess that means to be summarized, if you have an orthopedic issue, physical therapies should be seen first. Do you think we're at that point currently in our profession?
Before I answer that, you were talking about the risks going on with surgery and Chris Carroll. We had our course this weekend, and you brought up a good scenario. And yes, maybe wasn't a little over the top, but it still holds weight or water. And I think it should make, hopefully, our audience members think a little bit. We're going to challenge you a little bit. You mind sharing what you were talking about?
Was this the shoulder?
This was the shoulder, and you didn't know how to treat, so therefore they get X, Y, and Z. So therefore they get a surgery, and then I don't want to kill.
All right. So all right, stick with me, everybody listening in and everything like that. I should have a board in the back here. You ever watch Always Sunny? When Charlie,
I've only seen a couple episodes. Great show. I just
the meme of him like connecting dots. So hopefully everyone can stick with me. But we know in discussion with, especially, I'd say it's not even one therapist. I know a lot of therapists in the going off of our overhead throwing athlete episodes, but therapists, especially in the baseball realm, that only perform their treatment is only whatever exercises and just soft tissue to the shoulder.
Up north and
there's actually somebody local-ish to me. I think actually went to maybe the same school I did, but we digress. So I was having a conversation with Brandon and also with my student at the same time, and the particular individual says, we do that because our outcomes have been good. They're good enough, or they're good, and we had good results. Great. But to be honest,
lazy answer, but yes.
Huh?
Very lazy answer.
Very lazy answer. But in my personal opinion, I'll never say that. I don't think if those words ever come out of my mouth, I hope someone says, Jeremy, it's time for you to retire. I don't think you can ever have good enough outcomes. Anything that you can get done in 6 sessions, work to get it done in 3. When you get to 3, work to get it done in 2. When you get to 2, get it done into 1. From a, just a skill point of view. Yes, you want to keep, people, we're talking about dependency and making sure people come to us for a first option, but I never kind of view things that way. I should always look to get better. as long as I'm a practicing and treating clinician. Or if you're an educator, get yourself better to pass it on to the next generation. But with that concept, with it's like, oh, it's good enough with what we're doing, especially in the case of a shoulder, and how many things that can potentially refer to shoulder pain outside of soft tissue. We're talking about the cervical spine, the CT junction, the thoracic spine, the first rib, the second rib, I've even played around and noticed things even further down into like the thoracic spine or lower ribs. Do some crazy stuff, being how close it's probably to the sympathetic nervous system. So how many individuals are we missing or end up in getting especially let's say pitchers, you MRI any pitcher at any level, at least let's say high school, you're going to find something. You're going to find a labral tear, some partial rotator cuff stuff. But we know that from research. So you sticking to your ways and not looking at outside the box. And let's say you're probably not assessing it if you're not going to treat those other areas. How many of those individuals have consistent pain? It doesn't quite get better. And then they look for alternative options, whether that be injections, and that can lead to further degrading of the tissues if it's over abused, or into a surgery. And then when I took it one step further, as I typically do, including my jokes at times, unfortunately, but what happens to that person gets a complication. I said death, which is a little bit grim, but we're talking about axial nerve injuries, other things, other injuries that can end a person's career. How many people don't come back? I mean, the statistics on surgeries, especially like labral, is not very good. It's almost closer to a career ender than a career saver. For some, they do come back. But, could that all have been prevented if we, level up in the sense of, making sure we check off all our boxes and make sure we examine and treat everything that can possibly be related to said area. But that's what it was. I hope everyone stuck with me on that one. Next time, I'm bringing a whiteboard and having ties in and the articles and crazy faces and up till 4:00 in the morning with 6 cups of coffee. But
yeah, well said, Jer. Great question. Rarely are we dealing with life and death, at least in the musculoskeletal realm. But
what do you think, right? I mean, those individuals
take it those few steps further, and it's like, could you have helped avoid an unnecessary treatment? And it's so commonplace you don't think about it, and too many PTs are just relying on what they learned in school. The amount of conversations I've had, oh, well, school taught us this, school taught us that. The amount of stuff I see on social media, Facebook with the groups that are on there where people pose questions and, well, I was taught in school. Or if that's your constant reference and you went to school, even a year ago, but 3, 5, 10 years, and that's your point of what's kind of backing you up, dude, like, you're way behind. You need to, like Jeremy said, level up. You need to go take some good courses, or maybe do a residency or fellowship and expose yourself to some different thought process. I think the biggest thing with our advanced training is being exposed to different thought processes, being challenged, because too many times you hear, and maybe you're doing it yourself, oh, my outcomes are good enough. No, they're not. The fact that you even just said that is a problem. I mean, I've heard that from people taking our courses, and they're over here asking advice on X, Y, and Z, or they're burnt out or whatever, and the first thing is, well, my outcomes are good enough. Well, clearly not, if you are asking me about how to treat a certain case. And that's not said to be belittle you or anything like that, but when you know more about Tiger King than you do about whatever's going on in your profession, well, your outcomes probably aren't good enough. But going off on rants here, circle back to your question you asked me: should our profession have the privilege of treating or being known for MSK off the rip? Oh man, that is That is something to untangle. In a perfect world, I'd say yes. In the world I live in, yes. And with the training I have had and the experience I have had, yes. But I understand we are, the 1% or probably less than the 1% of therapists that have gone on to do a residency and fellowship training.
2% in the whole world, if you wanted to know.
2%. Oh, that's higher than I thought.
In the world for like fellowship level trainings.
Yeah, that's still higher because you double board certified is like around 1 or 2%, let alone fellowship, which is more of a funnel going down.
Yeah.
I get in, New Zealand and Australia. I mean, that's more commonplace and, overseas and stuff like that. But all right, 2%.
From what I heard, I haven't looked at statistics. I saw someone else put it, and I believe them.
Which you shouldn't do, right? All right, we'll fact check that. But regardless, right? Most PTs aren't there yet. Compound the models that people are in where they're seeing 4 or 5 people an hour. They don't have the time to see that, right? Or to actually, be able to do that. So, that's a layered thing. I think we should strive to be there to do that. I hate to dare throw this out and add the, division against the profession as well. Should you make it, if you have a certain amount of training or a certain amount of years or a test out or something like that, you have that ability to be known. I know some states of direct access is, 3 years or 4 years or 5, whatever the number is, before you get direct access. I mean, I have mixed opinions on that as well. But there does need to be more of a standard. There's too much, haphazard. We teach courses, almost once a month, if not more. And the amount of people we hear they just do soft tissue for 20 minutes. Like, there's very little thought process in what they're doing. Part of that can be because of the lack of time. Part of it's the lack of knowledge. Part of it's a lack of skill set. Like there's a lot of variations in there too, but soft tissue massage for 20 minutes is not that efficient. It's not effective. That's why massage therapists book 45-minute to an hour massages one-on-one, right? We need to be able to, get a patient in front of us, rule out the red flags, right? And what's this big thing on like social media, red flags that's going around? I don't know.
No idea.
I'm not hip enough. Not hip enough.
The medical world got into the social media world. I was like, oh, cool. That's awesome.
Speaking of that, right? We need to rule out red flags, find out what's going on, and then be able to perform a quick intervention and retest them. A lot of times it could be done in 5 minutes. So, if we're at that of a primary provider for musculoskeletal pain, we should be able to do that and see a bunch of people in an hour, documentation aside, right? What do physicians do? They see, and then they talk in their recorder and they move on to the next person. But they, rest for 2 weeks and see me in 2 weeks. Like no thought. When we have them on the table, we could just easily manipulate them, mobile them, nerve glide them, do a couple exercises within 5 minutes and move on. Like we can have the ability for being effective and efficient. You just have to hone that skill. Last thing here, tell you want to say something. That study was done by John Childs. I'm blanking on the year. Had to be like 2004 or 6 or something, right? Who has the most MSK knowledge? Well, PTs, DPTs with an OCS resident, or not resident, with an OCS board certification have the highest knowledge of MSK pathologies next to an orthopedic surgeon. So more than a student, more than a general practitioner, more than internal medicine, more than a neurologist, more like you go down the line, we were second to somebody who cuts the human body open for a living. That's pretty damn good. So instead of, how many times do people go to their primary care physician for low back pain? They're not helping you. They don't know what the fuck to do. I'm serious. Like they're going to give you prescriptions and they're going to give you a script for PT or give you a script for an ortho. Not efficient at all. And yet you have these insurance companies that mandate gatekeeping of you have to see a primary care before you can see a PT or anybody else. Like, how is that efficient at all? That's, if anything, increasing healthcare dollars, at least in the US. I don't know what it's like anywhere else, but that question has so many tentacles. Should we strive to be there? Yes. I think APTA wanted to do that. Yes. Did they fail? Yes. Did we fail? Yes. There's just so many layers to that. You got me heated up, man.
I can tell this is good. This might have to change the title of this episode.
The Brandon ranting.
Brandon ranting, or becoming private. We've talked about it, but this is more dive into the layers here. But no, I wholeheartedly agree. I don't think we're there yet. I think we have a long ways to go. I think APTA did try. They try to push a movement to you couldn't become a specialist unless you went through a residency, and then there was pushback, and then the same with the fellowship training is like you shouldn't be able to do a fellowship without doing residency, and then there was a pushback from this particular fellowship group, which layers on top of each other. I mean, at least people, there's a pushback for those individuals who want to push themselves and take these tests or trainings and that sort of stuff. But I don't think we should be able to. I think there needs to be something to ensure that individuals that are practicing direct access or have the aptitude to do it. I look back on all the times where I was either a shadower, aide, worked as a PT, and was unfortunate around some PTs that, their examination wasn't even anything. They nodded their head, put people on hot packs, gave them 4 exercises that they typically would do. This doesn't matter anything lower body, the same 4, and that was it. Didn't ask for any red flags. Didn't even do anything reflexes or cranial nerves or anything like that, or even have any general screening questions. So, and I look at myself as when I came out of entry level, and I had some great mentors and CIs. I still probably wasn't skilled enough to really say I should be a primary practitioner. But the training obviously helped to where I confidently can do that, and I've had a lot of people come in for that, and they tell other people, and we've built this nice little ecosystem of where we are the primary practitioners in our local area for neuromusculoskeletal stuff. But I think it took years of training to get to that. Do I think it needs to be a years of experience things? No, it's like giving someone a promotion is because they were the company the longest, which I think is absolute bullshit. I think it should be the most passionate, driven person who's going to make your team grow or your company grow, whatever the hell you want to think of it. But no, I think there needs to be something that says, I think in Texas, they recently finally, I think they were like one of the last states to finally authorize direct access. And it's like, I think 7 days, you have 7 days to treat someone direct access if you're residency trained. And then it's like 14 for fellowship, or I might be mixing it up. But, and that's a core component of residency and fellowship, is to be ability to screen out any red flags and see who's appropriate, and to be efficient, so that, people are like, oh my God, just 7 days, a real, fellow or resident or high level PT is like, okay, at least within 7 days, I know I can be making an impact, and the patient will know. If it's something way off and that sort of stuff, then yeah, I can always refer out and that sort of stuff. But 7 days, you get 2-3 sessions in, you can make an impact, or at least know you can help the patient. There's certain cases, especially high irritable people and that sort of stuff, those 7 days will be murky, but at least they can get that. But I don't think every entry level therapist should just come out and be able to do these things unless they prove otherwise. Maybe it's just like what are those tests called when you can take a test and skip a couple classes in college or something like that? I forget what they were, but pretty much test docs. I think, if there's something like that, add it to the boards, make it an optional thing if you want to. If you're like, I'm going the neuro route, or cardiac or peds, there is no direct access, screw it, don't take it. But I think that's what it should be until it becomes, and I see that in the future is, eventually it's just going to be DPT, roll right into residency, And then some people will choose to go on to fellowship, but the APTA did try that, and unfortunately we didn't push it enough, I guess. But yeah, I guess that's my rant into it. If you argue with me, that's fine. That's probably because you're well versed enough to be able to do direct access and see these people by yourself. But I guess we should circle back probably to our original question.
The main question.
To probably
I think it's
people,
time.
if you've listened up to this point, you really want to know. Do you feel like manual therapy is a sidestep over? Is it shake and bake over? Are you ready? You ready for
Yeah,
it?
I'm ready. I'm gonna take
ready?
this head on. I'm
All right.
on the train. I'm on the tracks.
You're on the tracks. All right, it was good, but
Oh.
I loved it. I love the sidestep. This was good. Got me all fired up for the rest of the day after this. But yeah, going back to it. Do you think manual therapy creates dependency? And then going beyond the whole, people depending on us to be a primary practitioner to answer those questions immediately, which I think is huge. I'll throw this in real quick. Anybody that I've seen quickly, acutely, like it start off just being friends and family members, and they'll just pop in like day 1 to 3 of their symptoms. They're almost done by the end of the week, or if not done by the end of the day. We don't get that often, but if we become those individuals and that's the case, we're starting to see people with symptoms day 1 to 5, our outcomes are going to be through the roof. But from just a dependency on manual therapy or unnecessary dependency on the whole physical therapy utilization, do you think manual therapy does that?
Not if you don't spin it that way. If you become salesman, if you, and this is stereotypically talking about another profession where you need to come 3 times a week for the rest of life, then yeah, you're going to be dependent because you're going to manipulate you're using your knowledge on somebody who doesn't know the area or body part that, yeah, they need to. You're going to fear monger, whatever the case may be. So yes, if you spin it that way, if you educate that patient that way, yes, it's going to be dependent. If you educate the right way, if you empower the patient, if you show them how to self-manage, for things that they can, and you educate, hey, try this on your own. If it's not, come back, or anytime this bothers you again, just come back. We can knock it out in a session. No, it's not.
Totally. And just to go off the top of that, we talked about on this show before, is I think for the most part, for every manual technique that we give, we always, pretty much for me, for the most part, unless I get them on a bike for just a cardiovascular warm up, stimulate the nervous system, I usually give them a self mobilization. So you're like, hey, you see how what I did there helped out, your range of motion, your pain got better, your strength improved, reflexes, whatever it may be. This is, the best technique you have that you can do at home. So we're trying to empower the patients. I think there's not even one profession we see in our own profession where these gurus that just stick purely to manual therapy, stick to the concept of let me fix you. Yeah, those are a problem and may kind of rely to that dependency. But I think this new wave of physical therapists and that sort of stuff, the anti-gurus out there, blending manual therapy with evidence, it is part of evidence, and exercise and education. It's a perfectly good tool. Have I been in situations where I probably did a couple extra sessions worth of manual therapy that probably wasn't warranted? Yeah. Sometimes you get into that and patient asks for it.
Then a day you have a business to run too.
Huh? You have a business to run too.
At the end of the day, you have a business to run too.
Exactly. And even before it was my business and working for others, yeah, it happens. And that's okay. And again, thinking what's the worst, it's not, I wasn't like, all right, let me manual therapy them for 60 minutes. It's all right. They wanted a technique, their pain's minimal or none. Screw it. If it helps them psychologically to get through the next 40, 30, 45 minutes of the exercises, whatever it may be, I'll do it for a couple extra sessions. I'm better about it now of like, hey, things are good at this point. I don't think you need manual therapy. Let's focus on the exercises and getting back to the function that you want to do. But I'll have to say this kind of thought process, this fear of patient dependency, that this is like cocaine, manual therapy. I think that it's leading to a group, especially younger clinicians, where they won't do it. And now think of all the people that you won't get better. And we talked about this on the show. What about the chronic pain patients and those people that have responded well to manual therapy? Or like how many people end up having pain and chronic pain or going down that route because we fail to modulate their symptoms. And, they hurt to move, and we'll just say, keep doing these exercises, it'll get better. Movement's great. And it just, their body, their system, whatever it may be, didn't allow it. And they just avoided the motion. And then 2 years go by in COVID, and all of a sudden they haven't extended at their back in 2 years, or in their neck. Could that all have been avoided? And are those people ending up down that other scary roads of drugs and injections and surgeries because we failed to perform manual therapy at the right time? But
yeah, and the famous, and to quote Rick James, cocaine's a hell of a drug. I will finish up with this. I've heard people say, clinicians, quote unquote leaders or experts, say they don't do manual therapy, yada yada. All they do is strength conditioning or Therex, right? And they've been asked, what makes you different than a strength conditioning coach? And their response is, humbly, there's not. They're the same. So I will ask, why'd you go to PT school then? You could have, you wanted the DR in front of your name? Because if you're just going to do more strength conditioning and not, utilize the rest of the scope of your practice, in terms of differential and advocating and educating and manual therapy, whatever, all the tools that we have, then start questioning yourself. And if you're that therapist, hopefully, you're listening, and, if you're following these exercise movement only gurus, then why'd you even go to therapy school if you're just going to do strength conditioning? You should have just done an NSCA or CSCS or some test like that, and you could have been done with only $500 of debt and could have moved forward. But you decided to go this route, and if you're 35 or under, chances are you have a substantial amount of student loans. All right, you better make it worth it and hone your skills in as many ways possible.
Yeah, I think there's a particular Esker, I'll say his name if he's listening and wants to call me out on it, but it was his words on a podcast. John Rusin, he said he hasn't done a day of clinical treatment since he's graduated, and he has his own, kudos to him, has his own, con ed and that sort of stuff. But you look at it, it's strength and conditioning, and we have more than that. I mean, yes, it's a huge piece of it. And should physical therapy look a lot like strength and conditioning? Absolutely.
At times.
But take and everyone's had him, a full-blown ridic. That's, you can't strength and condition that. And if you can, email me, message me. I'd love to hear how you do that, where you can just go straight into someone who came and stand up, has got a lateral shift, pain, potentially some weakness, loss of sensation down the leg, and you tell me how you can just, let's do some barbell squats or goblet squats, whatever it may be, because you're pretty awesome if that's the case, and kudos to you. But I think we have obviously a lot more to give in modulating symptoms and getting people back without the need of anything excessive, invasive, unnecessary that we discussed before. So that'll be my last points, unless there's anything else there, Brandon.
No, I think that's it. My computer's actually about to die, so
perfect
timing.
I gotta finish more of my beer. I'm slow today. But all right. Well, awesome episode, everyone. And yeah, I think the end of the recap things, unless Brandon, you have something. It's now recording now, but
what do we got? What are we in? October 21st. Let's see. We have our upper extremity course November 6th. I don't know if this is dropping before that. We actually have another course the 13th, 14th. Actually, that just sold out. So we're packed on that one. And then we have our spinal nip course December 3rd and 4th. And that one usually is a sellout as well. So we have that. We have our mentorship stuff, online virtual mentorship. Jeremy's also starting up rehab coaches, which is more for the entrepreneurial PT as well. Anything else? I think
no, that's it. Some exciting things, and soon the 2022 schedule will be out for our courses, and looking forward to it. And I'm honest with everything. You guys want to send me an email about stuff, by all means, I'd love to chat about it. But cheers, everyone. Great episode.
Until next time.